Good morning, everyone. I'm Dr. and today I'm going to present the public transplant rejection and its long-term management. And in previous lectures, we have already discussed about the post of complications of transplant. And today we will basically focus on the transplant rejections. Now, today's our learning objective will be transplant rejection in diagnosis, basically histopathology, treatment of the rejection, and the chronic practice problem. First of all, to know about the rejection, we have to know about the immunology of rejection. The antigen risk measure for rejection of genetically disparate tissue are called histocompatibility antigens. They are recorded on more than 40 domains, but local risk measure for vigorous rejections are of the major histocompatibility complex. MSC is also called HLA system, and it is located in the short arm of chromosome 6. The completion of several minor reasons also external rejection response. MSC are indicated basically as an haplotype or two half sets, one from each parent. So a person is usually half identical with each and half parents with respect to MSC complex. This also leads to 25% chance that individual might have a siblings which is HLA identical. The HLA genes code for three major classes, that is class 1 alleles HLA, B, and C, and three major class 2 alleles HLA, DR, PQ, and polymorphism in HLA, especially HLA, A, B, and DRQ are important biological barriers to a successful transplant. As closely HLA matched, the graft is less likely to be recognized and rejected. Now, the MSC molecules are divided into two classes, that is, class 1 molecules and class 2 molecules. Class 1 molecules are normally expressed in all nucleated cells, whereas class 2 molecules expressed only in the antigen-presenting cells, such as genetic cells, activated microorganisms, and B cells. The MSC molecules present the antigenic peptides to T cells. And the T lymphocytes only recognize an antigen if it is presented with a complex with the MSC molecules. The MSC class 1 molecules are responsible for presenting antigen peptides within the cells. That's the antigen from intracellular viruses, tumor antigens, and cell proteins to CD8 T cells, whereas class 2 molecules present extracellular antigens, such as extracellular bacteria to CD4 T cells.
Dr. Vikalpa, sorry to disturb you. Please talk near to mic. We can't hear you clearly.
Ji, Dr. Hanimala, basically, class 1 molecules usually present the antigenic peptides from within the cells. I will show you the direct and indirect pathway, then you will understand. Let us slide. Now, the mechanism of rejection. Rejection is a complex process of rejection is a complex process in which the respiratory immune system recognizes the graft as polymorphic and attacks it. It involves cell-mediated immunity and circulating antibodies. The T cell plays a central role in the rejection of the graft. And the rejection reaction consists of sensitizing stage and infected stage. Sensitization stage is mainly due to the presence of cell. The graft is being recognized as a foreign object by a recipient CD4 cells. Whereas in the effective stage, it involves the activated recipient T cells entering the graft and locally producing cytokines and helps B cells to produce antibody. Now, the cellular rejection is usually tissue mediated, and destruction of graft occur by CD4 cells and cytotoxic lymphocytes and CD4 plus helper T cells. Delayed hypersensitivity reaction is triggered by CD4 and helper cells. And basically, it involves two pathways, that is, direct pathway and indirect pathway. Here we can see in the direct pathway. In case of the direct pathway, this is the antigen-presenting cells, and the class 1 molecules usually express the antigens from inside the cell to the CD8 T cells. Then CD8 T cells become activated and it This is the antigen molecules, and it recognizes the antigens within the antigen graft cells, and it presents to this antigenic peptide to the CD8 cells. Then CD8 cells become activated, and it causes direct endothelial injury by binding to the renal vascular endothelium, as well as it binds to the renal tubules and causes tubulitis. And in case of indirect pathway, this is the recipient antigen presenting cells, and the antigenic peptides are presented by class 2 molecules to CD4 T cells. The CD4 T cells become activated, and it further activates macrophages with the help of interferon gamma. And these are activated macrophages attached to the tubular epithelium and causes tubulitis. This is also called the indirect pathway because T cells further activates B lymphocytes, and B lymphocytes activates plasma cells, and which helps in the antibody formation. And these antibodies further attach the renal blood vessels and endothelium, causing endothelitis and injury. These are the direct and indirect pathway. These are the things previously explained. Now the morphology of rejection. Morphologically, rejection can be classified as hyperacute rejections, acute rejection, which can be both cellular and neural, and chronic rejection. Now the hyperacute rejection. Hyperacute rejection is most dramatic and destructive events, and there is a immunological attack on the graft, resulting from the circulating complex complement fixing IgG antibodies, especially reactive against incompatible donor antigens. And it engages and destroys vascular endothelium within minutes or hours after vascularization. It usually occurs in the avio-incompatible grafts because of high titer of pre-existing antibodies against drug antibodies. And on burst examination, kidney becomes cyanotic, motile, and flaccid. When there is a neutrophilic accumulation and leading to the occlusion of capillaries and fibrin necrosis. And it is basically treated with the graft nephropathy. Now these are the light microscopic examination in first image. We can see this is the efferent arteriole, and there is a thrombus in the efferent arteriole, and the extensive necrosis of the graft glomerular trough. This is the glomerular trough, and this is the organogenesis within the cerebellum. And in the picture and second picture, this is showing hyperacute rejection with a mass vascular injury. These are the fibrin strand on the intimal surface, and this is the wall of the vascular wall is reduced by fibrin necrosis, and there is a minimal neutrophil infiltration. These are small neutrophils. Now, acute rejection. It occurs because of the initial exposure to class 1 and class 2 cell antigens. Antibody caused injury by complement-dependent cytotoxicity, inflammation, and antibody-dependent cell-mediated cytotoxicity. The cellular rejection is usually in cellular rejection there is a mononuclear cell infiltrates, and in neural rejection there is usually a vasculitis. Acute cellular rejection seen within 1 month after transplantations, and mononuclear cell accumulates in glomerular and peritubular capillaries, leading to focal tubular necrosis. And the place of endothelitis is a pathology. Acute neural rejection, also known as rejection vasculitis, and there is a necrotic vasculitis characterized by intimal thickening, and there is a presence of complement background product, that is C4 staining. This is also an indicator of neural rejection. Now, in this picture, this is also a light microscopic examination of the kidney biopsy, where you can appreciate multiple tubules. These are the tubules, and the tubules become atrophied, and there is a necrosis with the tubules, and the deposition of mononuclear cells with the tubules. This picture is depicting features of tubulitis. These are the tubules. And second picture, this is the artery where we can appreciate the intimal thickening, and endothelitis. These are the intimal hypertrophy. In third picture, this is the artery with the graft sclerosis, where the lumen is obliterated and replaced by the fibrin thrombi, and there is a intimal hypertrophy, and the lumen is obliterated narrow. So instead of graft artery sclerosis. Now the chronic rejection also known as
किसी को समझ में आ रहा है क्या है सेलुलर रिजेक्शन, क्या है एंटीबॉडी मीडिएटेड रिजेक्शन, क्या है और से आती है ट्रांसप्लांट रोटेशन किसने की है cellular rejection or hormonal rejection, humoral rejection में क्या होता है एंटीबॉडी मीडिएटेड रिजेक्शन आवाज आ रही है सेल मीडिएटेड और एंटीबॉडी मीडिएटेड रिजेक्शन में क्या डिफरेंस है अभी डिस्कस हो गया तो नॉट कंसंट्रेट
Cell-mediated rejection, we have two cells, cytotoxic and CD4 and CD8 cells, which along with major histocompatibility complex, they causes a rejection and ultimately lead to the endothelium injury, which causes the thrombosis or necrosis of the respective arterioles or the other tubules. And the antibody-mediated rejection, it can be directly due to the already presented antibodies in the recipient blood due to the antibody-antigen mismatch. Second number, it can also happen by indirect pathway in which the cellular immunity leads to the activation of antibody-mediated rejection.
How will you diagnose that this is cell-mediated rejection and this is antibody-mediated rejection, Dr. Naseem? What will be the difference on histopathology? This is the thing which just have been discussed. This is a boring topic. If you not concentrate, then you will not learn about it.
Sir, one will be at the level of cellular structure, like glomerulus, etc., and the other will be like
इनकी cellular structure क्या है?
like glomeruli, tubular proximal, convoluted tubular at this level.
Okay. अब rejection में क्या difference होगा?
And in the body will be at the level of vessels.
How will we come to know that this is cellular rejection or this is antibody-mediated rejection?
With biopsy.
What you will see in biopsy? It was present in just previous slide. What will be the difference between two? Listen, if you hear the presentation with concentration, then you will come to know. Otherwise, nobody will learn about it. Cellular rejections, when there are two types of rejections: antibody-mediated and cell-mediated. Okay, and you have gone through the mechanism how these both are carrying into the allograft, transplanted allograft. So in cell-mediated rejection, this rejection is being caused by CD4 and CD8 positive cells, and antibody-mediated rejection is being caused by preformed antibodies which are present into the recipient. They are taken onto the graft. So in cell-mediated immunity, there will be inflammation caused by the acid of inflammation with especially CD4 positive cells around the areas where there is inflammation. Inflammation will be at the level of glomerulus, top of capillaries at glomerulus, and around the Bowman's capsule, and peritubular structures. Peritubular structures means around the tubule and vessels around the tubules, especially arteries. There was atherosclerosis. So presence of excessive CD4 and CD8 positive cells will show that this is cell-mediated rejection, and absence of these cells and staining of antibodies will diagnose the case of antibody-mediated rejection. This is the difference. This was our present in this slide.
But like in hyperacute rejection, so there is a presence of rebound antibody. So in this case, we usually going for biopsy, not for going some blood test to check for rebound antibody.
Hyperacute rejection is caused by pre-formed antibody,
Yes, sir.
especially in acute completable patients, hypersensitive patients because of more foreign body interaction like blood transfusion.
So for confirmation, we will be going for biopsy or to check the blood level of rebound antibody.
Time frame will tell you about the hyperacute rejection, and otherwise biopsy will confirm it.
Chronic rejection, also known as chronic allograft nephropathy, and histologically it is characterized with the presence of interstitial fibrosis and tubular atrophy. It is associated with gradual dysfunction, graft dysfunction, and eventual graft loss, and it does not respond to anti-rejection therapy generally followed. Now, this is the histological of chronic rejection, where you can see a graft artery sclerosis. This is the artery, and there is a luminal narrowing, and these are multiple tubules which are distorted, and the suggestive of tubular atrophies, and there is the interstitial fibrosis. All these are tubules which become atrophied and distorted in shape. And this is the graft artery which becomes sclerosed. It's the luminal narrowing, and there is the interstitial fibrosis. Suggestive of chronic rejection. Now, immunosuppressions. Now, the objective to develop a method, the basic objective of immunosuppression is to develop a method that permits a recipient to keep a transplanted organ in a state of tolerance or non-specific unresponsiveness. Immunosuppression session can be used in one of the three ways. That is, first, during the induction with a high dose to prevent a primary immune response immediately after transplantation. And secondly, as a maintenance therapy, once the engraftment has stabilized, and additionally in high dose to treat acute rejection if it arises. And these are the immunosuppressants that we use. The first is corticosteroids, and it acts by inhibit synthesis and release of cytokines. Anti-lymphocyte drugs that can be further divided into CNI inhibitors or mTOR inhibitors. Cyclosporine, tacrolimus are CNI inhibitors, and they basically act by inhibiting activation of polycythemia genes. And mTOR inhibitors are sirolimus and everolimus. Antiproliferative drugs are azathioprine, mycophenolate mofetil, and cyclophosphamide. And these act by blocking urine biosynthesis and cell division. Furthermore, anti-lymphocyte antibodies, these can be polyclonal, monoclonal, and the polyclonal antibodies, anti-thymocyte antibodies, monoclonal antibodies that depletes lymphocytes are rituximab, alemtuzumab, and veromon of CD3, whereas monoclonal antibodies that are not depleting are daclizumab, basilizumab, and bilharzumab. It means it does not deplete the number of T lymphocytes in the blood. And these are the commonly used drugs. Prednisolone, azathioprine. The basic commonly side effects of prednisolone are in long-term use, hirsutism, osteoporosis, and features of secondary adrenal insufficiency can occur if there is a sudden movement of the drugs. And azathioprine, the common side effects are leukopenia, alopecia, hepatotoxicity. And the cyclosporine is a CNI inhibitor, and the basic side effects are nephrotoxicity, hypertension. And its important side effect is irreversible decrease in glomerular filtration rate, acute microvascular disease with a pattern of thrombotic microangina, and it also causes chronic irreversible renal damage. The tacrolimus side effects are neurosis, diabetes, hyperkalemia, hypomagnesemia, mycophenolate mofetil. Its side effects are also leukopenia, nausea, vomiting, cramps, diarrhea. Now, let's come on the diagnosis. Now, when to suspect the acute rejection? Acute rejection should be suspected if one or more of the following parameters. If there is a new increase in serum creatinine of more than 20% from the baseline, or a serum creatinine that is higher than expected. Another is worsening hypertension. Another is proteinuria more than 1 gram. And if the plasma donor derived cell-free DNA more than 1%. Once there is a lysis of the graft, then the DNA is released in the plasma, and there is a increased donor-derived cell-free DNA in the plasma. Now performing the diagnosis. Then allograft biopsy is the
If serum creatinine is not declining to the normal level within the due period, this will also be the indicator of rejection in early stages. If creatinine stops to decline, then this will also indicate. This is very necessary when you should anticipate, you should suspect the rejection earliest possible time to prevent more destruction of the graft. Delay in diagnosis, delay in suspecting and diagnosing their case will have delay in treatment, and they will have more number of nephron loss. So stop the decline of creatinine will also indicate the rejection. We have to very well about.
Now, renal allograft biopsy is the standard method of diagnosis. It helps us to accurately grade the cell-mediated rejection, differentiate between the T-cell-mediated rejection and the antibody-mediated rejection.
Let's repeat the symptoms which will indicate the rejection. Mindset.
Decrease in serum creatinine or not coming to the baseline, hypertension, and different donor differentiated fixed cell DNA in the converters.
That's important. Things will show you that there is something wrong. Urine output भी कम होगा जो हमारे presentation में नहीं. This is what nobody is raising the question. जो transplant में rotation कर रहे हैं, वो frequently देख रहे हैं. हमारे तकरीबन almost all patients, not all but many of the patients show the signs of rejection because of any of the reason, like low doses of drugs and plasma concentrations of the drugs are not achieved and whatever. But we commonly do biopsies of these patients, and the people, doctors who are on the rotation in the transplant are helping to must know what are these symptoms. You have to concentrate on it. Something deficient in presentation you should have consciousness to raise the point. First point when things worsen in the patients is declining in the urine output, when we are being alarming that there is something wrong. Uncontrolled hypertension and decreased urine output. These are the earliest possible signs. You have to talk about it. Even ground tenderness is also not common, but also the sign that there is inflammation going through into the graft and graft is being swollen.
Indeed, the biopsy helps us to differentiate between the T-cell-mediated and the ABMR. It helps to determine the degree of irreversible kidney damage, and also helps to reveal the other causes of renal inflammation and injuries, including CMV disease, weakened nephropathy, also known as polyomavirus, interstitial nephritis, spinal nephritis, recurrent or de novo glomerular disease, and post-transplant lymphoproliferative disease. Now let's move on to the acute T-cell-mediated rejections. It is usually caused by T-cells that react to donor histologic antigens present in the tubules, interstitial vessels, and glomerular arteria. The pathological changes are interstitial infiltration with mononuclear cells, and occasionally incidents with the disruption of tubular basement by infiltrating cells. And the TCMR, acute TCMR rejection is further classified by one classification and graded as following. So the first is a borderline. In borderline, there is a mild interstitial inflammation plus any tubulitis or significant interstitial inflammation. In type 1A, there is a significant interstitial inflammation with foci of moderate tubulitis. This can be further clarified in the following images. Now, this is the past stain, and in picture A, this is showing a case of borderline TCMR rejection. Where you can see a mononuclear cell infiltrates within the liver tubules. And this is the case of mild tubulitis, and in case of B, there is a feature of moderate tubulitis, which is the increased number of infiltration of the mononuclear cells. And in case of 3, this is the case of severe form of tubulitis, where the tubule becomes atrophied and there is a breach in the basement membrane. And in case of the G, this is the case of vasculitis. This is the artery, and there is the endocellulitis and vasculitis, where there is the infiltration of lymphocytes within the vascular walls. B. And in case of B, this is the case of severe tubulitis, where the endothelium and the arterial wall is obliterated, and there is a large number of lymphocyte deposition. Now, active antibody-mediated rejection. This is caused by circulating antibodies which binds to the donor adhesives on the graft on endothelial cells, which results in inflammation, cell damage, and ultimately graft dysfunction. The diagnosis of ABMR requires 3 components. That is histological evidence of tissue injury, evidence of antibody rejection interaction with vascular endothelium, and that is C4D staining in the peritubular cells. The C4D is a degradation product of classic complement pathway, and this is the pathognomonic feature of the antibody-mediated rejection. And serologic evidence of circulating DSM. And histological findings include capillary endothelial swelling, arterial fibrin and necrosis, fibrin thrombi in the granular capillaries, and severe case frank cortical necrosis. These changes are more commonly seen.
What is DSM?
Donor specific antibody.
How they will cause, how they will show that this is, what are donor specific antibodies? What they show, what they indicate. Right? Donor specific antibodies. Dr. Baba.
Sir, here will be a finding of acute rejection like urine output decrease, level is not declining. All feature will be present. So one of the confirmatory tests are workup test is donor specific antibody, which is done in acute rejection.
Donor specific antibodies means
The antibody of the
graft
donor
is exposed or identified as foreign body into the recipient. And graft is identified as foreign body into the recipient, then there will be donor specific antibodies. If these antigens from the transplanted kidney are exposed or identified as foreign body at some point of the time, that point of the time may be the time when graft is in rejection and things are deteriorating.
Now this is the light microscopy. This is showing a section of anal biopsy, and it is showing antibody-mediated rejection, where we can appreciate polymorphic nuclear cell infiltration within the interstitium. These all are the interstitium, and these are infiltrated by the polymorphic nuclear cells. And this is the artery, and this is showing endothelium.
Professor used to rotate the computer.
And this is the immunofluorescence study, and it is showing a C4D staining. All these yellow stains are the features of C4D staining, and it is a consistent with antibody-mediated rejection. This is the pathognomonic features. These all are the C4D staining in the peritoneal capillaries. Now the treatment of active antibody-mediated rejection. The patient with active ABMR can be treated as outpatient basis also, but because of the complexity of the treatment, the inpatient management is usually advocated, and the treatment of ABMR relies mainly on the retrospective studies and the empirical treatment guidelines rather than the clinical evidence. And our primary goal of treating ABMR is to remove existing donor-specific antibodies and to eradicate the donor population of B cells or plasma cells that is responsible for their production. Now the approach depends on the approach of initial treatment depends on the presentation. of timing of AVMR. That is, if the patient is diagnosed with active AVMR within the first year of the treatment, within the first year post-transplant, then we treat the patient with a combination therapy with glucocorticoid, plasmapheresis, intravenous immunoglobulin, and in some patients with rituximab as follows. We basically give the pulse dose of glucocorticoid, that is ibipitide at a dose of 300 to 500 mg daily for 3 to 5 days. Then we gradually trigger to the patient's previous maintenance dose of oral prednisolone. And if the rejection occurs at the maintenance dose of 5 mg, then we augment the dose to 7.5 to 10 mg per day. And secondly, we do the plasmapheresis daily or every other day, that is alternately for a maximum of 6 sessions or until the serum creatinine is within 20 to 30% of the baseline. After plasmapheresis, then IVIG is administered at a dose of 100 mg per day and after each session of plasmapheresis. And after the final dose of plasmapheresis, IVIG at a dose of 500 mg per day for 1 to 2 days is given with a cumulative target dose of 1000 mg per day. And if the patient has evidence of microvascular inflammation on biopsy, then rituximab single dose, that is 375 mg per meter square, after completion of plasmapheresis and IVIG is administered. Now,
Plasmapheresis क्या है? Why we are giving IV immunoglobulins after session of plasmapheresis? Dr. Mike then.
So plasmapheresis is basically to dialysis to remove the
Yes, remove. What we do in plasmapheresis?
So we remove antibodies from the recipient blood by plasmapheresis. We remove the preformed antibodies which is already present in recipient blood.
And this is why we are giving IV immunoglobulins after plasmapheresis, because if they are before, it will be washed out. Yes.
simple question. Before doing the CPA donor workup, don't we do the DSA level, so HLA typing, and it is already present antibodies in the recipient blood. Is there any concept of desensitization?
Definitely, if you visit the pre-transplant OPD and that workup, if patient is hypersensitized or has the history, recipient has the history of multiple transfusions or hypersensitivity reactions, like then these patients are being evaluated for that. Donor-specific antibodies are being evaluated before transplant and they are kept in record. And after transplant, when these patients, when you go through transplant rotation, you find antibody-mediated rejection patients, then these patients are being compared with before transplant workup and after transplant workup or during the time of rejection. So they do these things in selected patients. And we have seen the patients which were not able to get graft or get transplanted because of these issues, like these have hypersensitivity to the foreign bodies like blood. So they we don't have the mechanism to make these patients immune to that hypersensitivity and then go for transplant. We have seen patients dying over here on dialysis because they had people to give the kidney to them, but recipients were not able to receive these kidneys because of hypersensitivity. And we don't have here in Pakistan the system, and these patients are made immune and then go for transplant.
So while the rotation of transplantation, we have seen some patients, they with the nephrologist, he used to load the recipient with anti-thymocyte globulin before the transplant. The patient which is having a poor mass. So first they load with anti-thymocyte globulin, then they do the transplant, and after it initial period is very crucial when there is a diphtheria output or oliguria, the serial oliguria at very stable level. But after the inception of plasmapheresis or IV, IG and ATG, the patient recovers here.
Very well. This is true. We give ATG when there is overweight and before transplant in the operation theatre, transplant operation theatre. ATG is being given. This is an induction with ATG, and usually these are being prescribed in overweight allograft, but not the identical good match transplant. But this is a separate scenario. Overweight is separate scenario, and hypersensitized patients are a separate scenario. Hypersensitized patients cannot get kidney until they are made immune.
Sir, there are multiple options in treatment option for acute and chronic rejection which are reversible. But in case of acute rejection, there is a irreversible change in we will be going for nephrectomy. So that nephrectomy should be done on table because if it diagnosed on a table, that's a hyperacute rejection. So we will go for nephrectomy at that time or later on.
That is on-table decision. The patients are different. Professor MD is there.
These are table decision because when you remove clamps and that kidney is not paying and it remains below, so this should be removed on the table. This is rare nowadays because of the good immunosuppression and the induction with ATG and but you have to remove it on the table. But sometimes we confuse it with the arterial occlusion or the pink or something. I remember one case I was assisting in Germany to a surgeon. They were doing 30 transplants in a year with disease organ donation. So he did not remove the venous clamp, he removed only the arterial clamp, and he was waiting for kidney to get pain. So I was watching because I thought maybe it's their protocol and they give some time and then they remove venous clamp. So he was saying that this is hyperacute rejection, so we have to remove this kidney. So I told him that you haven't removed venous clamp, why? So then because 30 transplants in a year, so maybe he has done last transplant 3 months back, maybe 6 months back, I don't know. So then he said, oh sorry, then he removed venous clamp and then kidney became pink and it was good. So he was saying that I am thankful to you because I was thinking of removing this kidney. So I think if there is hyperacute rejection, if you are feeling that rejection is hyperacute, then kidney should be removed after.
During hyperacute rejection, the graph you are assessing on table, it is turgid at that time or it is flaccid? Because we can we kept the kidney turgid during the transplantation. Can we assess the kidney that this is hyperacute? Otherwise, it is pink or it is making urine, not hyperacute rejection. It is not making urine. It is not properly pink. It is flaccid or it is turgid.
It was present in the presentation, and I was asking to concentrate on presentation. There were 3 signs of hyperacute rejections on table: the sinus, muffled, congested. What was third point of flaccid? So turgid and flaccid are antagonism. And nowadays we also take biopsy when on table we see that graft is not pink and we get rejection. What we do is maximum utilization of the facilities to know that this is really hyperacute rejection or anything else like occlusion of vessels and clot or whatever. So we do biopsy, we do CDIs on table and then decide for removal of clot or not.
Lastly, after giving the TCMR, we augment the maintenance immunosuppression. And the patients who have treated with active MMR, the prophylaxis for active antiviral and antiviral is recommended, and the regimen will be identical in the immediate post-transplant period. And this includes prophylaxis against pneumocystis carini, CMV, and in some patients who have low risk of CMV always in place for 3 months. And if the patient do not respond to initial combination therapy, then the following agents like immunosuppression, bortezomib, tocilizumab, and infliximab, or in some cases, splenectomy can be known as rescue therapy. These were used previously, but these are not routinely used in nowadays. And if the patient develops rejections while under triple therapy with tacrolimus, microfiltrate, mofetil, and prednisolone, then we continue the agents at a higher dose if possible. That is targeting 20 to 25% higher than the previous level. And if the patient develops acute rejection during having dual therapy, then that is calcinated inhibitor or anti-metabolite without prednisolone, then we add the prednisolone at low dose, that is 5 mg long term daily. Now, monitoring the response, the patient with successful anti-rejection therapy will demonstrate improvement in the serum creatinine within the 7 days of treatment. And patient is considered to have successful reversal if the following point occurs within 3 months of the treatment. That is decrease in serum creatinine 2 or within 20 to 30% of the baseline, decrease in proteinuria, decrease in immunosuppression DSA by more than 50%, and the resolution of changes in repeat kidney biopsy. Now, this is basically the algorithm for the treatment. And certainly, the evidence, if the patient has evidence of antibody-mediated rejection, then we go for biopsy. And if the biopsy shows a mixed rejection, then we treat him as a mixed rejection. If the biopsy shows only the antibody-mediated rejection, and if the timing is less than 1 year and more than 1 year, if it is less than 1 year, then we treat with the combination therapy with the previously mentioned glucocorticoid, plasmapheresis, IVIG, and rituximab, and augment the maintenance immunosuppression. If the patient presents after the 1 year of transplantation, then plasmapheresis is not done, the rest of the treatment is same, because it does not have any evidence supporting the plasmapheresis. And if the patient responds, then we maintain the augmented immunosuppressive tools and routinely follow up. And if it does not respond to therapy, then we repeat the biopsy to exclude other ongoing rejection causes. These are the summary using the algorithm. Now, the treatment of acute TCMR. The goal of acute TCMR is to reverse the rejection and return kidney allograft function to as close as baseline prior to procedure. Now, the treatment of acute TCMR is usually based on the histologic severity. If the patient is having grade 1A rejection, then we basically treat the patient with glucocorticoid only, with a pulse dose of methylprednisolone 3 to 5 mg per kg daily for 3 to 5 days, and we resume the maintenance prednisolone therapy. And if the patient, in case of grade 1B, in grade 1B, the treatment includes the anti-thymocyte, antiglobulin. The rationale to use the anti-thymocyte antiglobulin in grade 1B is that in case of grade 1B, there is evidence of severe tubulitis, and this severe tubulitis is associated with worst graft outcome as compared to milder form of tubulitis. So, more aggressive form of treatment is given once the patient has ranked grade 2 and above severity. And the dose of thymocyte ATG is 1.5 to 3 mg per kg per dose, or 1 to 3 doses for a total dose of 3 to 6 mg per kg in the first year. And before giving thymocyte, we usually dose the patient with methylprednisolone, maximum dose of 500 mg. Then, prednisolone is resumed. With successful transplant or with successful treatment, the urine output increases and the serum creatinine starts decreasing within 5 days of therapy. And the expected reversal rate for the first episode of TCMR is 60 to 70% with positive glucocorticoid. And in case of rejection for grade 2 and grade 3, the treatment is with methylprednisolone and RTAC. However, the dose is increased according to the severity. That is, if the patient has a class 2A rejection, then the dose will be 2.5 mg per kg for 2 days, and if the patient has class 3, then dose will be 2 mg per kg for longer period, that is 4 to 5 days, depending upon the respiratory severity. And in case of if in severe rejection, the maintenance immunosuppression can be converted, that is from cyclosporine to tacrolimus or from azathioprine to MDA. Now, monitoring the kidney functions, the serum creatinine during the inpatient management, serum creatinine is monitored daily, and after the discharge, we monitor the serum creatinine on a weekly basis until it returns to the baseline or a new plateau of serum creatinine in the and donor-derived cell-mediated is monitored, which will be less than 1% within the 2 months of the therapy. And if the patient has a mixed acute rejection, that is both TCMR-mediated and antibody-mediated rejection, the treatment is with combination therapy, whereas RTAC, thymoglobulin, is added. And one thing is the RTAC and the above combination therapy should be given on an alternative schedule. That is, if the plasmapheresis and IVIC is given on the alternate day, that is Monday, Wednesday, then RTAC is administered on Tuesday, Thursday, that is intervening time. Now, coming to us, chronic allograft nephropathy, it is a histologic description rather than the disease entity that refers to the chronic interstitial fibrosis and tubular atrophy within the kidney allograft. It has been previously called as a chronic rejection, transplant nephropathy, chronic allograft dysfunction, transplant nephropathy, or chronic allograft injury. The chronic allograft dysfunction is a clinical condition characterized by slowly, that is over a period of weeks or months, the kidney function deteriorates, and it is usually associated with hypertension and worsening proteinuria. It results from a number of different causes, including CAN, recurrent or de novo glomerulonephritis, leaky virus associated nephropathy, late or recurrent acute rejection, renal artery stenosis, and occasionally urinary obstruction. And if it is likely to have the patient having, if that is a chronic dysfunction, in those patients who have early attack of acute rejection and infection. So to prevent the patient having chronic dysfunction, once we should prevent the acute rejection attacks. For the evaluation of chronic allograft dysfunction, the goal of the diagnostic evaluation is to identify the potential cause of the progressive kidney dysfunction. That we can do a Doppler ultrasound to exclude the renal artery stenosis. We can estimate the protein spot PCR ratio, and if the proteinuria is more than 1 gram per day, then we can perform the kidney biopsy. We can assess the presence and state of the DSA, and also we can assess the PK virus by measuring the PK virus viral load. And CAN, in case of CAN, the prevention and treatment includes prevention of rejection. Like I previously mentioned, we should prevent the attack of acute rejections, because the multiple attack of acute rejection can ultimately lead to the chronic graft dysfunction in long term. And the modification of immunosuppression, like reducing calcineurin inhibitors exposure. If the patient who is receiving cyclosporine for a long term can have a feature of chronic allograft nephropathy. So the modification of immunosuppressants can be done. And among patients with established CN receiving CNI, some evidence suggests that a decrease of such therapy may be effective at preventing progressive kidney dysfunction. This includes regimen with or without CNI. That is the addition or substitution of AMPRO in case of CNI, that are such as sirolimus or everolimus, or substitution of nitrogenated morphology for azathioprine or others. And other supportive measures include the treatment of hypertension, hyperlipidemia, diabetes, anemia, acidosis, and bone disease. And this is the EAU recommendation: provide lifelong regular post-transplant follow-up by experienced and trained transplant specialists at least every 6 to 12 months, and advise patient on appropriate lifestyle changes, potential complications, and the importance of adherence to the immunosuppression regimens.